Welcome, everyone. We are delighted to welcome you to our first webinar of the year, webinar number 42.
Welcome, everybody. We're glad you're here. My name's Hugh Brewster, and I'm here on behalf of the Circle of Cleft Professionals in Toronto, Canada. We're delighted that you've gotten up early, got through your midday, or stayed up late to hear this important topic about representation and equity in focus. So Operation Smile has said that they're moving to a new model of global surgery in terms of education and training. We've got two excellent guests to be able to share a little bit more and invite us into this dialogue, Dr. Elizabeth Cote and Dr. Ulrich Canmunier. Dr. Elizabeth is the Vice President of Global Medical Education at Operation Smile, and Dr. Ulrich Canmunier is the Health Policy and Advocacy Manager at Operation Smile as well. Dr. Ulrich has also completed the Operation Smiles Fellowship Program. So guests who are steeped in this topic. And without further ado, I'm just going to pass the baton. We've been practicing this technically. Dr. Elizabeth, you've got it. And let's let you share your screen. Niti will stop sharing hers. We'll hear from you. And then obviously, as Niti has shared, we'll spend quite a bit of time in just discussing what does this mean? And how do we really resonate and engage with these terms of equity and representation? So over to you.
Well, thank you so much, Howard and Niti. We couldn't be among better company with all 11 organizations that are represented in the Circle of Cleft Care Professionals and accompanied by Dr. Ulrich. We are representing policy and we need to attack this problem of a global shortage of surgical professionals from all sides. And one way we're finding, as many of you all are in the field, that one of the most sustainable ways to do that is through education. There's been a call in the literature since at least 2018 that the medical mission model is no longer the most sustainable way to make a difference in the critical gap, but education is and can be. And that's where Operation Smile is firmly headed. That's where our investments are being made. And we wanted to share with you a few practical examples of that today so that we can hear about your examples and just share that knowledge. Simon Sinek says that you should do business with people, not who share your business model, but who share your why and your purpose. And I feel like here we're in great company for that. So if I can move to the next slide, this is a slide you've seen many times before. We're all very familiar with this heat map of where there's a lack of professionals, of healthcare professionals. It represents the physician, but we are equally focused, as many of you are, on the entire surgical and non-surgical team that makes up the comprehensive care a child born with cleft and other essential surgical needs requires over their lifetime. And so there's another way that we define this problem, and I'll hand it over to my partner Ulrich in a moment, but it's to look at it through the eyes of the patient in a patient-centered way, not just as a numerical problem, one that we are really familiar with defining through the Lancet goals as provider density and distance from a provider, which is a felt experience, but one that is the distress of a child. So here you see many of you are health practitioners yourselves, the Wong-Baker pain model of the child's faces that help pediatricians assess the pain of a child. And we don't want to see crying, anguished children anymore. I mean, how can we pull on the heartstrings any more than that? How can we make this heat map look really different, and more importantly, much more equitable? I think that's usually the diversity of color is a beautiful thing, but in this case, it's not. This is not equitable. How can we make this look like a much more level playing field? How could we make it look something more like this? And it begins with education and educating more people so that there are local providers who can provide care in the language of the child who needs care, who live close to the child's home and can provide follow-up care, can coordinate that care, and can provide even more than cleft care, but other essential surgical services to the child. And then you see this heat map is now a more peaceful blue the key to the map has more smiling faces on it. And while it's a metaphor, this is also the 2030 goal, the Lancet goal. The surgical workforce density problem is one we're all facing and tracking down, and education is absolutely a key path towards addressing it. And so Operation Smile is committed to investing in the surgical workforce. Our mission is to invest in the surgical workforce globally until every child has access to quality cleft and essential surgical care close to their home. That doesn't mean that someone flies in close to their home, but they have care close to their home that they can access. And we know by 2030, here's some good news, that while the surgical gap estimates from the World Health Organization are still quite large, they're actually decreasing, except in sub-Saharan Africa, where with population growth, it's still increasing, and 50% of that surgical workforce gap will be in sub-Saharan Africa by 2030. So having given a little lay of the land of why are we so focused on investing in the surgical workforce and what is the problem that we're all focused on sharing, I'd like to hand this over to my partner, who will have Dr. Ulrich, who will have another view and more to share on the problem and on the paths towards the goals that we all have in common. Ulrich?
Thank you so much, Dr. Elizabeth Cote. So we had a really brilliant introduction to at least what this big problem is like. And we are all acutely aware of what it is. And that's why we prioritize it, whether it's from the Sustainable Development Goals or through the World Health Organization. For example, the World Health Organization has a human resources for health workforce 2030 goal, which aligns with the Sustainable Development Goals, but also with the Lancet Commission on Global Surgery. So what are these goals we are chasing? If you're looking at what the WHO has made its target, it is to increase the number, the skill mix, and the competency of health workforce within low and middle income countries. And we know that this also means not only being able to recruit new workforce, being able to retain that workforce. And to do this, we need to achieve at least 90% of national health personnel being within the country. With a globalization, that has meant that there is a lot of exchange. Dr. Cote mentioned Sub-Saharan Africa being one of those regions that is suffering acutely from a deficiency in health workforce. And this deficiency is going to be impacted by a number of things. Obviously, there is the growth that is expected to double by 2050, but there's also the fact that there's going to be freedom of movement and people within the Sub-Saharan African region, thanks to the African Continental Free Trade Agreement, which is being implemented by a few countries. So what that means is probably we're going to see even more movement to urban regions from one country to another, but it's also the aftermath of the COVID-19 pandemic on the continent. And this, at least in some ways, can be seen in other regions, but less acutely as it is seen in the Sub-Saharan African region. And so it's about the creation of jobs, quality jobs, but also empowering the local health workforce so that they have the necessary leadership skills and governance skills to strengthen the health system to the next level. So that was looking at it from the World Health Organization's perspective. And this is talking about the health system in general. Cleft conditions and people affected by cleft are tended by this health system. So it's rightful to look at it from a microscopic view, but we can zoom in a little further. We know that with cleft, we will have interventions in the form of surgery, anesthesia, speech pathology, nutrition. And so we can turn to the Lancet Commission on Global Surgery that suggests 20 health workforce in terms of surgery, obstetrics, and anesthesia for our patients, and even be more specific by looking at the pediatric surgery indicators. We are 6 years away from the 2030 deadline. And so what can we do to get there? This is where education plays an important role. This is where we want to make sure that we are catalyzing our efforts and we're hitting our goals as much as possible. Dr. Cote.
Ulrich, I love when Ulrich adds to the conversation, and you can see that, at Operation Smile, like in many of your organizations, we are thinking about this in a push and a pull. And once education happens, as Nelson Mandela said, education is the most powerful weapon with which you can change the world. And it's not up to us as a central accrediting or controlling body to say, if we are going to invest in the education of an individual healthcare provider, whether that provider is a nutritionist or a speech language therapist or a cleft surgeon or a perioperative nurse, then that provider must stay where we think, from where we're sitting in Toronto or Virginia Beach or wherever we are, they should stay in some specific ecosystem. Education is power, and people are trying to do the best they can for their families. So given that, we need to create systems that help meet the need. And so we have a policy department also thinking about these push-pull mechanisms of, if we invest, where can we invest most wisely? For education, I want to give the example that we're trying to choose whom we invest in very carefully. For example, we'll choose women we'll choose many qualified candidates to invest in, but we do know in the literature from developed and from high income and low income countries that women, first generation higher income, and first generation university students and first generation medical professionals are more likely to stay in their home communities because they're most affected and allied with that call to give back and serve the problems that they experienced firsthand. So that will factor into scholarships, for example, that we give as selection criteria. There's talent everywhere, and there's not educational opportunity everywhere. There's more talent than there is scholarships at this point. But if we all come together as a community collaboratively, perhaps we could match that. I don't believe there's more talent than there is resources and access to education in the world, especially with the breakdown of barriers that comes with our virtual digital society. Then there's changes in policies that can re-incentivize and help to retain people where they are. And we also know that education is something that is indestructible, and it gets passed on. We're going to talk about this a little later, generation to generation, so that even when we train, for example, a surgeon who gets cleft competency, they're likely to train another, and they train another. And while they might migrate to an urban center or a high income country, their trainees may not. And so as part of the sustainability, we know these investments are good investments because education grows on its own exponentially. And we just came back from Morocco. I'm sure all of you are in different places, coming and transiting from other places too, where we were able to train a Palestinian team along with many other Middle Eastern teams who are reinforcing each other. So I like to say about education, even if the world seems to stop for those of us in the high income or investing space, if there's an earthquake in Morocco, if there's a COVID epidemic, if there's a war in Gaza, if there's a conflict in Ukraine, we still see that professionals who are trained are doing everything they can to take care of their neighbors in their living rooms. And that's what's so powerful about education and why we believe in it. And they're still training their neighbors and others in a core competency way to go on and to amplify that impact. And so you see this graphic of how we believe, as many of you do, that training the comprehensive operative and non-operative team can actually lead to, should we do it efficiently and all together, realization of these ambitious goals. For Operation Smile, it's reaching 1 million patients. For United Nations, universal health coverage. For Lancet Commission, we know those goals very well. And so the next part of this presentation, now that we've shared a lot of the lofty ideas, was to talk about two examples of many. There's many, many, like all of you have, different programs and initiatives. We organize our educational initiatives by user, so by vertical, whether it's by nutrition, speech and language, psychosocial, surgical, anesthesia, nursing, pediatrics, biomed, and create products for that. We actually don't create products, we cultivate them. I'm kind of like a beverage distributor, actually. Just take a sommelier, you might say. We just create, we cultivate, like, what are the best options of competency-based training and out there, and then try to deliver them to where the need is, to be honest with you. So if I, worked for Coca-Cola, that could be another way of thinking about it. And we changed the formulation because we have regional teams that then adapt it to the local context and variety. So we have many products and then many applications of it, like all of you do. But now we're going to go into 2 examples. And the first one we call the cleft surgery training program. Many cleft surgeons and supporters in the cleft space have been involved in developing this program, which started back in 2018. Megan McCullough was the lead author on a paper in the World Journal of Surgery in 2018 that came out. It was also written by Billy McGee, who's our chair of research and education and innovation. And this basically showed that a competency-based model was adequate for allowing a surgeon to acquire with repeated observed exposure, mostly gained through the vehicle of a short-term surgical program, which you might historically think of as a mission, under the supervision of a mentor, the competency of that mentor. Now, there's a big argument for that, especially in low resource settings where setting up new residency programs or creating even new spots in existing residency programs is very costly, expensive. And even in high income countries, we know it's also, it requires a lot of administration, and it puts up a lot of barriers. Is that the quickest way for us to get high quality? We don't want quality to suffer, high quality care closest to the child. It might not be. And so I'm sure this concept is not new to people on the call, but it suggests that the practical approach includes both active teaching and hands-on practice, and that these high fidelity models may be preferred by surgical trainees, and the costs and resources involved might be more amenable and scalable for low-income countries. So the cleft surgical training program identifies surgeons, promising surgeons in low and middle income countries who could be licensed, may already be licensed to provide cleft.
Pero jamás se hizo en el sillón.
But have very little exposure to clefts, for example, and then helps them have access to that hands-on training in a high repetition, high fidelity way over a period of time. We find generally that about 21 days of intensive repetition, and that could vary, depending on what this surgical schedule looks like, brings competency up by 70%, especially in markings and especially in simple procedures for cleft alone. Now, using a really, really conservative model for impact assessment, let's say the surgeon has a career of 50 clefts, a career where they perform 50 cleft surgeries a year, because we know that the surgeon's probably in a low-income, middle-income country doing a lot of other procedures, burn procedures, tumor procedures, and the cleft is only a small part of that. There's limited OR space as well. And then they have a 20-year career. That's also very conservative. That means they do 1,000 surgeries. That's much more than direct service could provide when you have a visiting professor from another country, for example. And so that's 1,000 surgeries. Now, that's the cleft surgical training program. It's a validated model. It's been revalidated many times. So it's something we create cohorts around with curriculum, co-curricula, and the cohorts also, that's another retention mechanism. They strengthen each other's commitment to staying and reinforcing each other. there is, as I'm sure many of you are doing, and I see this in the literature, there's simulation involved, there's tele mentoring involved, so there's long-term mentorship involved. We also help them go to conferences, so they're exposed to even more procedures than just on this like competency-based program. And hopefully they train more. So if they train one more surgeon, you could say, okay, that leads to 2,000 surgeries. So now, I just want to end with we can all focus on that. Hopefully this will help us focus together on the fact that ultimately training in low-income countries can be optimized by providing high fidelity models as much as possible when budgets allow it, and combining these different models of virtual training and teaching with senior surgeons in intensive ways. Even in the US, a plastic surgeon can graduate with very few cleft cases under their belt, and they still need a high volume to get to a high level of competency. So here's a very new publication that I love, and Natalie Myers and Lawrence Kai, came out the 5th of February, that modeled the lifetime impact of reconstructive plastic surgery training for building capacity in global surgery. I'm going to focus specifically on the cleft cases, but this was a literature review that looked over a number of generations after training surgeons, and found that the lifetime impact of training a surgeon in cleft lip repair, when you looked at the multi-generational impact, was very high, much higher in low and middle income countries, in fact, than in high income countries. In a high income country, training one surgeon in cleft lip repair resulted in almost 52,000 attributable cases. But in a low income country, that led to 134,000 attributable cases. This is an amazing and a very compelling business model for educational investment. No matter where that surgeon goes later, we know they're training other surgeons, and we know that's spreading the impact of what can be done, who is receiving care, and how close that care is being delivered to the child. So in addition to the amplifying effect of being in a low and middle income country, because perhaps there's more throughput, or perhaps there's less dilution of the caseload, there's also a really important multiplier effect in LMIC countries of training generations. And maybe that's a lack of exposure, and maybe it's also an avidity to be trained. We talk about the thirsty provider, the hungry provider, so very much when we are presenting, and there's so much talent that is unmet talent that is so thirsty and hungry for education in low and middle income countries, that it's such an honor to be a distributor of education. And so we can see here, again, just coming from our experience at Operation Smile, that already in Madagascar, we have 3 generations of cleft surgery training program graduates, and you will see on a local program with few international volunteers, Dr. Romaine and Dr. Joelle and Dr. Adrian operating together. So teaching together, running tables together. And then when they're not doing an intensive cleft training program, they'll be doing clefts on their own. And they also, of course, have their own community of practice now. In Morocco, same thing with Professor Nawfal, Dr. Houghton, and Dr. Houssa. And now, especially in Morocco, where right now there's very little ability for visiting professors or for mentors to come in and out of the region, those physicians are helping physicians in the MENA region. So we just came back from an intensive educational planning summit, where we planned out the educational programs for the entire year. And you can see the movement of these trained physicians across countries to help train others. And it's really a beautiful thing to see, where we're really just catalysts for what people want to do for themselves on their own, for their own communities. Finally, the last example I wanted to give is one that's happening. It's day 2 of 3 days of a nursing conference in Ethiopia right now, where 31, the goal was 31 nurses have gathered from 6 different countries in sub-Saharan Africa. They all got their visas and they all got their confirmed flights. So that was the first triumph. And now they're training in really essential perioperative surgical skills and are receiving not just refreshers in these essential perioperative skills that are evidence-based and best practices, but they're being assigned professional mentors through a collaboration with Johnson & Johnson about how to go into the leadership space as well. And then technical assistance from Operation Smile and our large capacity of volunteers, which is virtual, because the idea is that within 90 days, they will be fully supported in delivering a capstone training to up to 30 peers in their home institutions. And they were selected knowing that that was the end goal. So this will be a time of investment in them to enhance their skill set, professional development to enhance their leadership capabilities, including speaking skills, stepping into their leadership skills, etc. And then technical assistance to plan these capstone projects so that in the end, by the numbers, and of course this is in progress, the impact could be that these 31 nurse leaders from 6 countries who are matched by 31 educators and facilitators and mentors, some of them virtual, will have 3 days of in-person training and 90 days of intentional capstone formation from both professional and technical mentors. Will reach 900 nurses with improved perioperative skills training delivered by peer leaders in their home communities within 90 days. From a past in diversity, equity, and inclusion at a national and some international levels, I know, aside from this work, that healthcare quality is higher when it is delivered by individuals who represent the patient population. And that makes sense. That makes all the sense in the world. When someone understands you, can pronounce your name, can remember your name, can speak your language, understands your culture, understands how you experience your pain or may present your pain, is there for follow-up, is there to understand what else is going on and act as an ambassador, maybe even a primary care liaison for the rest of your family, the quality of care increases. And that's why we are saying that education can change the face of global surgical inequity, not just the faces of children born with a cleft condition, but the face of who gets to deliver the care, who gets to, with talent, receive the education, and the faces of who gets to access that care, whether they're in the periphery, the last kilometer, or in the hubs. And then that care is not just increased because of provider density, increased because of access and closeness to a surgical site, but it's a higher quality and it's more appropriate because of that match and that increased representation and equity in the healthcare workforce. So with that, I just, again, want to thank you for such good company. There's so much work to do. I want to invite everyone to collaborate on this work. Those are just 2 examples. And I'll stop sharing my screen. Ulrich, anything you'd like to add, my friend?
I think we have some hot topics and debates that are coming up. I'm looking forward to it, actually.
Oh boy, I fortunately have not been paying attention to the chat yet, so let's get on that.
Excellent. Thank you, Dr. Ulrich. Thank you, Dr. Elizabeth. We've got a great turnout this morning, and you've given us a wonderful introduction into the new global training emphasis and how that's going about. As Dr. Ulrich mentioned, there are some questions already posted in the chat. I'll give everyone a second to think about their own comments as well, as we always do on these webinars for the next 20 minutes or 25 minutes or so. Feel free to raise your hand if you'd like to ask a question directly. You can post it in the chat and we'll try to work our way through. And I think that the first question I'd like to ask, it really builds on Matt Fell's question from the UK. And I was twigged also this topic of high fidelity models. And here Matt Fell's asking, is Operation Smile planning to focus on certain types or methods of education, or is it undertaking a trial process to see which educational interventions have the most impact? So can you just very briefly, Dr. Ullrich, maybe you were part of this one of these programs, you were a graduate of that. What does high fidelity mean to you, and how is this influencing how Operation Smile is moving forward with its training model?
Well, thank you. I mean,
Oh, I think we lost Ulrich for a second there.
the experience
Elizabeth?
is I was initially a global surgery fellow. So my training was sorry, can you hear me?
Yeah, you're back.
Yes. Okay. Sorry about that. So I said my experience, I was initially a global surgery fellow with Operation Smile. It's a program on the research and team, and we really focused on research but leadership as well. So what I got was the skills to move on to actually have the confidence to take up more opportunities and tasks, especially tackling some of the issues that are plaguing sub-Saharan Africa. So I've worked with a number of program countries and governments trying to address some of the questions that were asked, and I'm really looking forward to share that about the high fidelity and the evidence. Operation Smile has a number of programs and a number of techniques. So when I look at cleft surgery training program, CSTP, which I wasn't a part of, one of my colleagues was part of, and she's currently training at the University of Toronto Sick Kids after going through that. We have some mentorship and the integration of some of the volunteers within the Champions program. So there are a number of them, and there's always a monitoring and evaluation plan that is embedded into the different programs to constantly get feedback and improve on these programs from the user's perspective, but also from the mentor's perspective. So it's been a constant collecting data and then improving on it. Since Dr. Cody has joined the education team, she's taken it 1,000x, because the education team has grown, the number of graduates have grown, the feedback is overwhelmingly positive, and I think we're headed for newer and greater heights. Dr. Cody, do you want to add to that?
Thanks, Ulrich. You're very complimentary. I mean, I have the advantage of being a personal story is that I grew up in rural Maine, which you'd think is not a low income place, but at a time when the US didn't cover everybody for health insurance, and my sister had a long bone fracture and we didn't know how to pay for it. And I said, this is not fair and this has to change. And so here I am now with anesthesia and pediatric training. And I think, I'm making a bigger impact in this way, growing it in this way. High fidelity training means to me that it's as close to the actual situation as possible. And so one advantage of, what is unique about Operation Smile, why would Ulrich and I want to join Operation Smile and work there to make this inroad in education is there's a network of over 600 employees, but like thousands of volunteers. And no matter the impact they made and how they made it in the past, now we have the ability to work with people and relationships. And I really think it's the relationships that make, if we think about what made an impact on us, just think about the story of my sister, what made an impact on our training, you can think of a mentor, you can think of a living educational experience. I don't think there's any replacement for doing many surgeries. I think I did 300 epidurals at Brigham and Women's Hospital during my Harvard training, and I could do it with my eyes closed, right? Under the supervision of like a specific number of trainees. And that's pretty simple. But high fidelity means like your battlefield conditions, right? And that's very different. And this is where we have to be careful in low resource centers than it is with someone coming from a high resource center saying, oh, I'll help you do this. No, it has to be someone from a low resource center who is a master trainer helping someone in a low resource area say, I will help you do this in a masterful way X many times. And so I think probably at the end of being with that mentor for 3 weeks, that individual could have more cleft surgical experiences under their belt, I'm just postulating, right? Then the average plastic reconstructive surgeon from a generic, name your generic program in another high income country is possible. So that's what high fidelity means. We do simulation as well, but if we're doing simulation, we want to make sure that it's as high fidelity as possible. So we are and that's high expense too. So definitely believe in that, but kind of like paring back on being selective about that. If it's low fidelity, don't want to waste a lot of time there. Virtual is good for formation, for didactics, for sure, for seeing, but then you got to switch to, you get the knowledge, the formation, and then you got to switch to the practice, like they say in anesthesiology. A monkey can intubate by the time you're done with residency because you've done it so many times. That is an over exaggeration, and I'm just being self-deprecating by saying that, because that's what I was told in residency. So please don't generalize like that comment to anything else, but just that we really need to go to, I think, this competency, or really believe in this competency-based mentorship model.
Got it.
Well,
Thank you,
in addition,
Dr. Elizabeth.
yeah.
Right, I'm trying to get some more comments.
Sure.
I think one of the other elements that really, was a hot topic that came in the thing was the idea that if you're funding some sort of training program, that a high-income country, funders shouldn't have any influence over where a person actually applies that. And so, I think there's probably lots of people on the call who've had some experience with some restrictions going on to their funding. We'll go to the group first, but also, I'd like to hear any more about that. That seems to be a newer emphasis within Operation Smile to be less concerned about where people apply the training that they've been given. And I think, even Dr. Ulrich's one example, sharing our shared love of Cameroonian basketball players, but now you're living in Accra.
Oh, thank you very much. I love us discussing this topic. First of all, let's look at some of the existing scholarship programs from international development. If you're getting a Chevening scholarship, or if you're getting one of the Eisenhower scholarships or whatnot, usually it's you go back to your country for a couple of years, and after that you have freedom of movement. Because at the end of the day, there's an ethics around this, which is we're talking about human beings and they have their inalienable rights. There's not much we can do about that. That's people's rights. Like Dr. Cote said, what we can do is set up systems for them to be retained within those spaces. And that's where the whole health system strengthening is important. You can't just be working on what is definitely the most important part of the health system, which is the human beings. You have to work on the other aspects. That's where a department like the Health Policy and Advocacy Department is very important, because then it helps you interact with stakeholders, help you understand why are people staying, those who stayed, why are they staying, and those who are leaving, why are they leaving? And then you work towards that. Because if you work towards that, guess what? People will stay. But you cannot say because I'm funding, I'm having you stay in so place.
Interesting. One of the elements of retention, Dr. Yuri, a pioneer for comprehensive cleft care in Eastern Europe and Bulgaria, has pushed is that idea of team-based care and how you build out teams that would allow someone to really want to stay and be involved in some leadership capacity in a comprehensive cleft care model. I'm not sure how Operation Smile is wrestling with that idea.
We are doing that actively right now. In fact, we're helping our countries. So we've really switched to this locally driven, globally supported idea of helping countries, just assisting them in identifying where's your hub and your spoke. Can we identify the rising stars or the members of a sustainable operative and non-operative team, fill those teams in, so that now, and then train them up, because in every single position, we have something like CSTP or the nurse training program, and then we place them along with on short-term surgical programs or on externships with high fidelity, repetition. So whether you're a biomed or you're a nurse or you're doing speech, there's that comprehensive team. Now you belong to a team. And many of us have these experiences. I was in Iraq for, post-war building that didn't work out. But what keeps people going back out in the battlefield is their buddies. It's when you go through an intense experience together, what keeps that grit, what keeps you bonded together is that you're doing it with other people and you share it. And so that's another retention strategy, really, because it's just a strategy to create meaning in people's lives. And that's what people are seeking. So we are doing it because that's how children are going to get care. If there's a surgeon but no anesthesiologist, they're not going to get care. And actually, educating pediatric anesthesiologists is a very high leverage point of attack for us. But agree with that completely. The whole team, wonderful strategy.
Thanks. Another element that's being pulled up here, obviously one of the elements that traditionally has been associated with Operation Smile has been the mission model, and as also Matt Fells put in this idea of volunteers and how that's there.
Mhm.
And I'll weave in Dr. Fernando from Brazil's a comment also, even about, when there's missions happening or some of these training things, the idea that care is being, or patients are being held for the international volunteers as opposed to some of the local staff. How is Operation Smile wrestling with this dynamic?
It's a very open conversation. Albert can talk about it too. I mean, one of the more recent missions, we don't use the word missions, but short-term surgical programs that I've been on was in Peru. There were 200 people. 25 of them were from outside the country, and only 15 of them were from the US. So we really are thinking about now strengthening regional and within country mentors and mentorships and those connections. So locally driven and internationally supported, because the talent is there. It does need to be amplified. And sometimes in places like South America, it's actually just fractured into the private sector. So get resources out of the private sector back into the public sector, especially in plastics, for example. Also, the other strategy that's been really useful is leaning on the fact that, yeah, it's been a strength for, it's been criticized, but it's also been a strength that Operation Smile has run, except for during COVID, short-term surgical programs. And now I see those as intensive educational immersion experiences. And so the volunteers we're looking for now are different. We're looking for educators who don't want to impose the way they do things, but want to embrace meeting the mentees where they are and bringing them to the next level. And as close as those mentors come from, that's where the action's happening, the better. So we're trying, then we use our volunteer base to do other things like lectures on Operation Smile Academy, or visiting professorships when there is a specific need we can't identify being filled closer to the need. So yeah, much more intentionality having to go through it. And it's a big internal cultural shift that I have to commend a legacy organization still run by its founders for being so open to such a big innovation.
Thank you. So I'm hearing an education process that's going on specifically for volunteers also within the movement of a change in their role away from providing direct care, if I'm hearing properly.
Well, yeah, I mean, in addition to direct care, but also knowing that the most direct care is from someone that lives close to you. So now they're investing in those people that are most direct. So being into the teaching, they're becoming more the educators.
Right. And before we circle back a little bit to some of the training pieces, Matt Fells put another question just around the idea of volunteerism. So with the local people who are involved in these, what used to be called missions, and now we're talking about short-term intensive training opportunities. Are the local providers still volunteers? Is that essential part of the model, that everyone who contributes in these trips is doing it without remuneration?
No, we remunerate them with investing in their education. So we don't pay them.
Without financial remuneration, but
we don't pay them cash,
okay.
But we invest in them to go to conferences. We invest in them to be CASEXA graduates. We invest in them to, have these other educational opportunities, travel, have externships, for example. But they are part of a healthcare system, and our job now is to help them thrive in their local healthcare system, and not to intervene or create some sort of a vascular steal where if we're paying them for cleft care, now they're not doing maybe burns care that actually is more urgent, but just to help increase capacity and education.
That's helpful. Thank you.
Their skills.
And I've been talking a lot. Again, if you'd like to put your hand up, we've got about 5 minutes left for some of these comments, questions. We've got a question about going back to the idea of virtual trainings, and specifically, what kinds of skills, specialties is Operation Smile targeting, and who is it using as in general? Just who are you drawing from to do some of these virtual trainings in terms of the trainers?
Well, a lot of the training still happens in person, and virtual trainings. We do have a platform, Operation Smile Academy, but I'd say there's also, there's also the World Health Organization, wonderful international hub of resources online too. So we're drawing from our volunteer base basically to mark it up, and then people. What's wonderful about that is once the individual learner joins Operation Smile Academy, which I invite everyone to join here, Operation Smile Academy, and Ulrich, it's like operationsmileacademy.org, I think. But then you have your own self-determined path of learning. So a lot of people, think about how we all learn to do our skills. You can see 5 people do it 5 different ways, all the better. So now it's autonomous, and they can decide on their own what's happening. That doesn't replace or create competency, but it does help with learning.
Lovely. So we have some folks who have particular interests along there. In this, from Malaysia, Zainal is asking, is Operation Smile incorporating in part of its training program anything around peer support groups? Is that part of your remit?
Absolutely. It's essential in everything. When we do Women in Medicine Fellowships, the CSTP program, the peer mentorship is essential for not just retention, but just, for mental well-being, for resiliency and training, for helping each other, for sharing cases. In the same ways it is in high-income countries. So I think that's something that's super special to these programs, is having co-curricular programs, from the Global Surgical and Advocacy Fellowship Program to Women in Medicine Fellowship Program, to the Global Surgical Fellows Program, to all of we have now in every country an education coordinator, and they have their own community of practice where they're sharing the educational programs and what's working, what's not working. So these peer communities or communities of practice are a really important part across the board of helping people learn from each other and just scaling up natural learning and innovation.
Lovely. Another element that is part of what you mentioned is the idea of mentorship. Dr. Debbie Sell is asking a little bit more about your mentorship, how that works. How do you evaluate the effectiveness of a mentorship? Is there training that's accessible in terms of how to mentor well?
Yeah, that is. And we're building that out too. Operation Smile Academy we have units available now, because like you said, we have to shift even from seeing local providers as volunteers. Low-income people don't have the luxury of volunteering. They're local providers who we're investing in to have more skills and competencies. So we're investing in them because we respect them. They're not able to volunteer. But the idea about mentorship is educating about, okay, here's the focus now. It's not go in and do it the way you want to do it because we want a high throughput of surgeries. It's about we want to meet people where they are so that we can identify what their learning path is and how we're going to bring them to the next step to thrive within their own communities. So we're partnering with accrediting bodies, for example, like societies, so that if they're collaborating with Operation Smile, or if they're going through an educational experience with us, it doesn't matter if it's recognized or accredited by us. Who are we to do that? It's accredited by their local body so that they can have global continuing educational credits for it in their country of Ethiopia, or their local country. Ulrich, do you have anything to add to helping people thrive within their own and through mentorship within their own milieu, their own environments?
Yes, yeah, absolutely. One of the important mentorships I see when you talk about peer-to-peer, I think about Prof. Costin in Rwanda, and how he's helped train the first plastic surgeon in Burundi, and now he's working with him to set up a plastic surgery unit. And that goes back to when we're talking about retention, building the rest of the system around. You may have the best skills for cleft, but when you go back to a country, even if you're given the opportunity, here's a hospital, build a service. Well, your cleft surgery training didn't have those components of how you're going to be the head of a unit, what do you need, and how are you going to go about interacting with the stakeholders. That's an issue. So now talking about the mentorship elements of what makes a good mentor and the outcomes, it starts, and we've worked to facilitate this. It starts with the mentor and the mentee having that honest conversation of what do I expect out of this relationship, because that will vary based on what each person has. Some people are technically gifted and they want a more advice on how to deal with the non-operative aspects. Others want more of the operative mentorship. And so once they've defined that, then it's easier to evaluate the mentorship for them.
Thanks, Ulrich. And it sounds like a bunch of these elements are still being rolled out, as Dr. Elizabeth has mentioned. Dr. Ulrich has posted a link to the relatively new online learning platform from Operation Smile, so you can learn more about the resources that are freely available beyond just the Operation Smile community. I think we have another plug from some folks around that idea of multidisciplinary care. And so you mentioned training nurses and some other elements. How is Operation Smile Academy or your programs engaging with the idea that comprehensive cleft care is both multidisciplinary and interdisciplinary in its approach in an LMIC context?
Hugh, the training on Operation Smile Academy for nutrition, speech, and for psychosocial is very rigorous, and with the help of many consultants aligned with global standards. And there's like this online component, and then there's an in-person component. So if you go in Operation Smile Academy, freely available, it's very rigorous. So, and I'd say, I know we're at time, but like even more so than the others, which I'm not going to say they're more complex, but there's a little more variation because they're a little bit broader topics. But go online. Absolutely. We have many verticals and we see them all as equal. So speech is equal to anesthesia, is equal to nutrition, is equal to surgery. And we have, cornerstone didactic products there, and then trying to orchestrate these high fidelity learning moments that are hands-on with mentors. So it's innovative and it's a work in progress. Absolutely. And it's not perfect. We're just sharing the best of what we've learned.
No, and we're super grateful that you are bringing us into some of your discussion in the ongoing way of how Operation Smile is now approaching some of these training pieces. Thank you. You've given us a lot there to dive into. It's lovely that there is some online resources that people can examine on their own to sort of understand this new shift within the Operation Smile movement. And Dr. Ulrich, great to have you as someone who's experienced this both as a trainee and now as a member of the Operation Smile team to talk about this more. And I guess always, as we think about this beyond these different movements, what is something about this topic that's really stood out to you? Is there something about how you've been interacting with grant makers in terms of training around movement? Is there some idea of the stability of investing in men versus women that Elizabeth brought up? Is there something around some of these online modules and how you would assess the effectiveness of a training program or effectiveness of a mentorship relationship? These are all some topics that we've just started, and hopefully there's some fodder there if you're thinking, I have something to share about mentorship, or I have something to share about assessing how a medical training program goes and these long-term outcomes. What is the impact of these kinds of ways? These are things we'd love to discuss more. They're things we're all wrestling with as members of different movements, some of the 11 that are across the COCP network. And so we're super grateful to Elizabeth and Ulrich for bringing us in today. Niti, what else do we need to know?
So stay tuned for our next webinar, which will be exactly a month from today, where we will have Dr. Bernard Tanzbeck from the Philippines, who will be discussing with us their care protocols and the strategies they employ to overcome difficulties in providing comprehensive cleft care.
Great. Thank you very much. We're right at time. So it was a lovely conversation today, even if fewer people, everyone's shy, not putting their hands up, but thank you for participating in the chat and reacting. So we got some good conversation from the group, and we'll look forward to seeing you next time.